So welcome to today's event, Redefining Health Policy in 2020 and Beyond, Racism, Social Movements, and Well-Being. I'm Charles Briggs, co-chair of the Berkeley Center for Social Medicine at the University of California, Berkeley, one of the co-sponsors of today's event. The Berkeley Center for Social Medicine is part of the Institute for the Study of Societal Issues, along with co-chair Seth Holmes and ISSI's Associate Director, Deborah Lustig, who did much of the leg, or should we say finger work, to make this event possible. We try to get issues of health out of narrow boxes. Pushing beyond disciplines, we have affiliates from all over the UC Berkeley campus, pushing back against the way that universities so often operate in isolation. We have affiliates also from the University of California, San Francisco, Davis, Santa Cruz, Stanford, San Jose, and San Francisco State Universities. Moreover, we focus on dialogues with specialists in social medicine from around the world, working particularly closely with practitioner scholars of Latin American social medicine and critical epidemiology. I regret to say that the Vice Chancellor for Research has decided to close the Institute for the Study of Societal Issues, which would be a great loss for the center and for the campus and for far beyond. And I would like to ask you to join me in protesting that decision. More information is available at socialjusticefutures, that's one word, .org, and the link is available in the chat as well. Challenging the way universities often pretend that they are ivory towers, the Berkeley Center for Social Medicine also partners with health professionals, the people who are putting their lives on the line right now to face a very puzzling and dangerous virus. I'd like to give a virtual round of applause to all of you who are participating today, who are on the front lines of clinical practice. Thank you so much. In particular, the center is very pleased to continue our ongoing collaboration with National Nurses United, the California Nurses Association. We partnered on a great set of events with them last year, and they also co-sponsored and played a key role in organizing this event. So I now turn it over to Heidi Hoechst, who is the education lead for National Nurses United.
Thank you so much, Charles, and thank you, Deborah Lustig and Seth Holmes, the Berkeley Center for Social Medicine and the Institute for Study of Societal Issues for co-sponsoring this evening's discussion with National Nurses United and the California Nurses Association. As Charles was pointing out, our collaboration on our end with the Berkeley Center for Social Medicine has been an honor over the past couple of years, and we extend our solidarity in your efforts to protect the Institute for the Study of Societal Issues that has made discussions like this one possible. For those of you who may not be familiar, National Nurses United is the largest labor union of registered nurses in U.S. history, with over 150,000 members across the United States. Over the past year, even as nurses have been fighting for their lives on the front lines of the global pandemic and standing alongside their communities to combat the public health crisis of racism, our union has continued to grow and expand our commitments to advancing the rights of healthcare workers while leading the movement for Medicare for All so that nobody is ever denied access to necessary care. In September, nurses in Asheville, North Carolina organized a new union at an HCA hospital in what was recognized as the largest union victory in the South since 1975. This past week, nurses right here in the Bay Area held historic strikes in the midst of a pandemic, fighting against a hospital industry that has been determined to use this pandemic as a pretense for weakening protections for patients and for workers. And building on this momentum tonight, we are so grateful to be co-sponsoring this important discussion focused on the intersection of social movements and health policy. Even as we are facing some of the toughest challenges of our lifetimes, we've been inspired by the ways that our communities have built alliances and solidarity across race, across geography, and across sectoral lines to move policies that protect patients, policies that protect democracy, and policies that protect our collective well-being. So I'd like to thank our speakers tonight for sharing their perspectives on some of this transformative energy. And thank you all for joining us this evening to take part in this important conversation. With that, I'll turn it over to Charles, who will moderate the conversation.
Well, thanks so much. I'll tell you, it's inspiring always to be able to work with NNU. The format of today's event is that first, each of our three speakers, Jamila Taylor, Janene Yazzie, and Mari Lopez, will share brief prepared remarks. I'll introduce each one of them before they speak. Then we'll have Q&A. If you've got a question, please use the Q&A feature. Heidi and I will ask those questions on your behalf. Now, the planning for today's encounter started last November, and we were hoping for an April event in person. Well, let's just say that a few little things got in the way. I wish that we were gathered together today on the Berkeley campus and not locked yet again in the Zoom screen, even if this virtual format allows those of you who are sheltering beyond the Bay Area to participate. For example, Jamila is joining us from Washington. But COVID-19 and long due mainstream attention to white supremacy, racism, and anti-racist social movements did more than delay this event and force it online. COVID-19 is not unprecedented, as we are constantly told. Underlying structural factors and policy decisions predictably enable the virus to strike racialized minorities the hardest. Widespread protests are now expressing rage over police killings of African Americans and the lack of response over decades to demands for an end to violence against racialized minorities. Even as the pandemic has greatly increased the health, housing, employment, and educational forms of injustice, directed at vulnerable populations, events taking place right now in Washington, D.C. place the inadequate compromise known as the Affordable Care Act on the line, threatening to deprive even more millions of people in the United States of health insurance. I doubt that I need to convince many of you that these issues are deeply connected, or that transforming them demands all of the thought, creativity, work, and collaboration that we can collectively muster. But I think that rather than pretending that viruses and bacteria are natural causes of striking health inequities, we must transform COVID-19 into an epidemic of justice, making it a tipping point for creating policies and practices that embody inequality. And I am thus delighted to introduce our speakers, who, along with you, the other participants, will help us collectively forge new paths ahead. It is thus now my great pleasure to introduce Dr. Jamila Taylor, who is Director of Healthcare Reform and a Senior Fellow at the Century Foundation. She leads the Century Foundation's work to build on the Affordable Care Act and to develop the next generation of health reform to achieve high quality, affordable, and universal coverage in America. Please let's welcome Jamila Taylor.
Thank you so much. I am going to share my screen and get started. And greetings to you all from Washington, D.C. So today I'm going to talk about racial inequality in healthcare, really to set the stage on what we mean when we talk about racism in the healthcare context, as well as mention some of the policy ideas that have just recently come to bear in light of COVID-19 and the racial unrest that we've actually had in this country over the past few months. But first, a little bit about TCF. The Century Foundation is a progressive, independent think tank that conducts research, develops solutions, and drives policy change to make people's lives better. We pursue economic, racial, and gender equity across a number of policy areas. Founded over 100 years ago by progressive leader Edward Filene, TCF pursues its mission by conducting timely, nonpartisan research and policy analysis that informs citizens, guides policymakers, and reshapes what government does for the better. This presentation is going to offer an overview of racial inequality in healthcare and the role that structural racism plays in perpetuating health disparities. I'm going to start with some background, go over vast racial health disparities, define structural racism to help contextualize our conversation for today, talk about how structural racism manifests in care, how racism drives health disparities, and then end with some key takeaways, health policy efforts, and some resources for further reading. Studies conducted over time consistently prove that racism impacts social stratification and the ability of people of color to be healthy. And I want to state that this is about racism and not race. We know that there are historical foundations in this country rooting back to slavery, the genocide of Native people, as well as other issues that really ground this conversation and the view that racism is actually what makes people of color sick. There's no genetic reason why we see health conditions be disproportionately impacted towards people of color. Racist experiences bring on an increase of inflammation in people of color, leading to compromised immune systems and increased risk for chronic illnesses and even premature death. Exposure to racism over long periods of time can lead to the health and economic implications that cause people of color to suffer greatly. And then lastly, the burden of racism is inescapable for people of color without systemic change. We see vast health disparities across a number of areas. And, as mentioned previously, the ACA is something that we should be proud of as a country. But at the same time, people of color are still more likely to be uninsured despite of the gains from the Affordable Care Act. We have 9.7% uninsured rate among Blacks versus 5.4% among whites. Black and Native women are dying 3 to 4 times the rate of white women of preventable pregnancy-related causes. Black children, 10 times more likely to die by gun violence than white children. The COVID-19 pandemic, impacting Black, Indigenous people of color the most. We see that in terms of the disproportionate rates of cases and deaths among Native, Black, and Hispanic populations. And then I'll also say here that the social determinants of health are not always protective factors across a number of health conditions that disproportionately impact people of color. They impact us across economic and education levels. According to the Aspen Institute, structural racism is a system where public policies, institutional practices, and cultural representations work to reinforce and perpetuate racial inequity. In the conversations about public health and how structural racism impacts health, I hear a lot of advocates talk about implicit bias and the need to sort of start there, and then we get to the more overt forms of explicit racism. But in my opinion, we shouldn't work that way. We cannot address implicit bias without addressing structural racism. So how does structural racism manifest in care? Here are just a few examples. The first is that we see health provider shortages in lower quality hospitals concentrated in majority communities with Black, Indigenous people of color. We also see racial bias and stereotyping of Black, Indigenous people of color by healthcare providers. We see differential treatment practices and management of pain. Again, this is something that can be traced back to slavery. And this perception that Blacks have thicker skin or a higher threshold for pain. And this was a time where they were experiencing brutal beatings and even experimental surgeries without anesthesia or consent. We also see a lack of culturally responsive care that centers the patient and their unique lived experiences. We also see structural racism in efforts to undermine or sabotage publicly funded health programs, such as Medicaid. Medicaid is a program that disproportionately serves people of color. And then also I'd add, even with the responses to COVID-19, I think, no one listening in on this program today can deny that the response to COVID-19 has been inadequate. It's been inadequate for an illness that is impacting Black, Indigenous people of color the most. So we know that racism drives health disparities. We see this through research that suggests that the cumulative effects and the toxic stress of racism undermines their health. Again, this is due to the fact that people of color experience racism throughout the continuum of their lives. Racism is fueled by predominantly white power structures that perpetuate power imbalances. So that means the solutions that we come up with in order to address these power imbalances must be grounded in social justice frameworks that intentionally center Black, Indigenous, and people of color. So some of the policy efforts that have come to light, particularly in the age of COVID-19, as well as what we've seen in terms of, the elevated conscious, I would say, around racism in this country, are a set of bills, as well as a policy effort that I'll talk about here. The first is the COVID-19 Bias and Anti-Racism Training Act. This is legislation introduced by Senator Kamala Harris, and what it does is ensure that health providers and others involved in COVID-19 training, testing, treatment, and vaccine distribution, as well as other response efforts, receive racial bias and anti-racism training. The Community Solutions for COVID-19 Act was introduced by Senator Cory Booker. This bill would tackle COVID-19 health inequities and dedicate $1.5 billion to grassroots organizations in order to help them create and expand efforts to improve health equity in their neighborhoods. The Black Maternal Health Momnibus Act. A few slides ago, I talked about America's maternal health crisis and the fact that Black and Native women are disproportionately affected by maternal mortality. The Black Maternal Health Momnibus is comprehensive legislation led by Representative Lauren Underwood. And what it does is basically center Black mothers in the US response to maternal health. The Anti-Racism in Public Health Act is a bill that was introduced by Senator Elizabeth Warren and Representative Ayanna Pressley. This bill confronts the public health impacts of structural racism, including the disproportionate impact of police violence on Black Americans, inequities in health insurance and healthcare access, and it looks at the vast racial and ethnic disparities in chronic conditions. And then the last piece I'll mention here in terms of the policy efforts is a report that was put together by the Senate Health Committee just a few weeks ago, and it focuses on addressing racial health disparities. This report actually explicitly mentions racism as a driver in health disparities. And I have worked in Washington for over 20 years, and this is the first time that I've seen a comprehensive report like this that lifts up racism as a part of the conversation around health disparities and the health of people of color. So some of the key takeaways from my conversation today are first, the fact that historical foundations rooted in slavery and subjugation of Black, Indigenous people of color have important implications for the differences that we see in medical treatment and racial health disparities seen today. Prolonged exposure to racism has a wear and tear on Black and brown bodies, and this leads to premature death, mental health challenges, and chronic illnesses. Structural racism manifests in many forms. And again, this is about racism, not race. Here are a few items for further reading. These are pieces that I have written, and next to them are the places of publication. So the first piece here on racism, inequality, and healthcare for African Americans is a report. It includes more of a deeper dive into the historical foundations around racism and African Americans and sort of how we got to this place now where we still see inequality and racism in the healthcare system, which is deeply rooted. A piece that I wrote for Democracy Journal that focuses on racial health disparities, centering that conversation on COVID-19. I also bring in some of the pandemic recession impacts as well. And then this piece is focused on testing in communities of color. One of the things that I've seen in terms of conversations about universalizing testing for COVID-19 is that there's still a lack of targeted outreach and plans that really help to center communities of color, even when it comes to testing, even though we know that COVID-19 is disproportionately impacting these communities. And the last piece is a journal article that focuses on structural racism and maternal health among Black women. Thank you so much, and I look forward to your questions.
Well, thank you so much for sharing with us. That was a very rich presentation, and I'll tell you that that was a wonderful phrase. This is about racism, not about race. I'm certainly going to take that away from your presentation. Thanks again.
Thank you.
We'll now turn it over to Janene Yazzie, who is co-founder and CEO of Sixth World Solutions, which works with Diné, or Navajo, communities to develop projects, programs, and policies that promote sustainability, environmental justice, and self-governance. Welcome, Janene Yazzie.
Yazzie, and thank you. It's an honor to be here. And I'm also going to borrow a term from you, Charles, an epidemic of justice, which really resonated with me. Building off Dr. Taylor's presentation, there's a lot of things that we have learned in this moment and in this era of COVID-19 and how we have shifted to technology to bring us together and have important discussions in the midst of all of this chaos that we're trying to navigate. For my peoples here in the Navajo Nation, we've been in the midst of a hot spot since March and are now in the process of preparing for the second wave. And there's plenty of stories out there, I think, talking about what has happened and how our people have been this epicenter for quite some time. But I think it bears repeating and a little bit more emphasis on the root causes of our community's vulnerabilities. There's a lot of the deeper connections for why healthcare and the services provided in healthcare are disproportionately provided for people of color and for Indigenous peoples in general. But we also have very unique histories and issues regarding access to culturally appropriate healthcare when it comes to the services that are provided to Indigenous communities. And this played a huge role in the onset of this virus. Not only were the 8 healthcare facilities that service our entire Navajo Nation not prepared and not equipped with the appropriate testing equipment or the PPE to keep our frontline healthcare workers safe, but we also were still lacking a lot of the important health information that was needed for the community education and outreach around the dangers of the virus and around the needs for social distancing. And luckily, we have plenty of Navajo-speaking healthcare professionals who took it upon themselves to translate the material into the appropriate languages so that we could get that information out there. But that was after the virus already struck and started spreading among our communities. And so this lack of language justice, the lack of culturally appropriate care, the roots of supremacy and of colonization and the ways that that's created barriers to healthcare, all of these have come into play to bring us our most poignant lessons in the midst of this pandemic and the lessons that challenge us to do more and to do better. Because even in the responses, when we ignore those roots of those injustices and of those challenges that are faced from our people and accessing the type of care that they need, we can see that the solutions to and the responses to this pandemic can further exacerbate those inequalities. For example, in an attempt to try to stem the community spread in our communities, our border towns were shut down. And this has exacerbated pre-existing tenuous relationships between Indigenous and non-Indigenous settlers who have and profit off of the economies created off of the exploitation of the labor and of the communities on the reservation. Like we saw an exacerbation of those racial tensions. The shutting down of border towns and implementing of curfews and of of roadblocks to ensure that there are only people traveling for essential services, cut off one of the only lifelines for people to access food, clean drinking water, medicines, other medical treatments, and to also get treated if they were presenting symptoms of COVID-19. Furthermore, some of the responses that we saw being employed by healthcare facilities in general were also egregious in the ways that they played off and exacerbated racial disparities between Indigenous peoples who went to these healthcare facilities for help and for treatment. An example of this can be seen in one of our most notable women's health hospitals, Loveless Hospital here in New Mexico, which made headlines for targeting Indigenous women who came in to deliver based on their zip code and based on how they presented and whether or not they looked like Indigenous women, separating these women from their babies out of COVID precautions that the hospital instituted that greatly disrupted this critical bonding period and this critical time for a mother greeting their child coming into this world. And we're also seeing this in the offerings of vaccine trials and treatments to our communities, when we know that both the direct impacts and the secondary impacts have led to a loss of jobs, creating and exacerbating the endemic poverty that we were already experiencing in our communities. And so to offer vaccine trials without full information and full ability to ensure the free, prior, and informed consent of anyone who volunteers for these trials, and offering monetary compensation is egregious as well. And we're seeing this across all of our Indigenous communities, both in the U.S. and abroad. And in the U.S., we're particularly restricted because all of our healthcare comes down through federal programs and is resourced through federal programs. And so when we have people in power at the federal level that do not really prioritize the wellness, the well-being, or our own cultural conceptions of well-being and of healing, then we're going to see this opportunistic response that uses our population for vaccine trials without fully honoring the full inherent rights of our peoples and our communities. And so, I don't have to elaborate anymore on the disproportionate impacts on Black and Brown people in general, but I do want to talk a little bit about how we're also seeing the secondary impacts, increased acts of racism, not only against Asian Americans, which we can't forget in terms of how this is played out in our communities, but also against Indigenous peoples. Being in a hotspot, our peoples have faced and even more barriers, as well as these memories of historical trauma from previous pandemics. Our communities were struck with a hantavirus epidemic in the early 90s, and that led to a lot of racial tensions and racial violence against Navajos when they went into border towns, or anyone who looked like a Navajo. And so that's still very much a lived memory, and that was brought up in the way that the non-Native peoples surrounding our reservation reacted to our community members when we became a hotspot with COVID-19. These things don't just happen, and they're not the failure of any community's response or inability to govern. They're the product of generations of federal and state policies, of extraction and monopolization of wealth through exploitation of Black and Brown and Asian bodies, and the allocation of public and private funds through practices that privilege those who subscribes to the values and practices brought to these lands by settler colonialists who denied the humanity of every other race that does not fit into the ideals of white supremacy. There's this great quote from Ta-Nehisi Coates in Between the World and Me, and he talks about how these ghettos, which I felt was really also descriptive of the conditions that we find ourselves in here on reservations, but these ghettos, each of which was planned as a subdivision, they are an elegant act of racism. Killing fields authored by federal policies where we are all again plundered of our dignity, of our families, of our wealth, and of our lives, rooted in the assumed inhumanity of Black people, or I would say all non-white people. A legacy of plunder, a network of laws and tradition, a heritage, and a dream that is rooted in all of this. And so when we talk about making and transforming our healthcare policies and healthcare responses and learning from these lessons and building better and new, it's going to start by really deconstructing a lot of things that have become normalized, including how we look at social determinants of health and their link to white supremacy. You know, like the economic and social conditions that underlie social determinants of health are rooted in generations and legacies of environmental violence and lack of access to clean drinking water, and endemic and manufactured poverty and food insecurity and unstable economies, particularly on our reservations, where we have been forced to rely on boom and bust economies that come with the extractive industries. And it has also been rooted in the demonization of indigenous lifeways, ceremonies, medicines, food systems, and community networks and governance structures. And all of this for the intent, the purpose of disrupting all of this and of creating all of this inequality was to embed white supremacy and heteronormative patriarchy and even the values of organized religion so that they could facilitate our assimilation into a dominant American culture. These generations of violence carried out against Black and brown bodies has very real impacts, and has impacts that aren't normally looked at in the healthcare field. You know, from everything from the destruction of our sacred places to the displacement and continued violation of the bodies of our ancestors through the disruption of our sacred burial grounds, tell us, our people, that even in death, we cannot be free from the violence of white supremacy. And so we have to center culturally appropriate, place-based, and community-informed determinants of health and definitions of well-being. Another quote I want to leave you with is from Resmaa Menakem from My Grandmother's Hands, Racialized Trauma and the Pathway to Mending Our Hearts and Bodies. And he says, in today's America, we tend to think of healing as something binary. Either we're broken or we're healed from that brokenness, but that's not how healing operates. It almost is never how human growth works. More often, healing and growth take place on a continuum and with innumerable points between utter brokenness and total health. In addition, trauma and healing aren't just private experiences. Sometimes trauma is a collective experience, in which case our approaches for mending must be collective and communal as well. So we're not going to fix this issue by creating a health policy that ensures that we get the appropriate rapid testing, the appropriate healthcare responses, safe vaccine and fair and just vaccine trials. But we're not going to transform our healthcare system or our conceptions of well-being until we do that effort to dismantle white supremacy in all of the ways that it shows up across these institutions. And for our Indigenous peoples and my colleagues that I work with, they have been developing different methodologies in care and in understanding the impacts to our collective and individual well-being, as well as the responses and approaches to that. So everything from developing healthcare policies that improve like the functions of our healthcare systems and the access to our healthcare systems, to ensuring water as a human right, to ensuring fair housing and access to housing, to ensuring that we eliminate the barriers that are preventing that are preventing the quality of life for all peoples. We'll continue to build back and create a response that further embeds us in the status quo.
Thank you so much for a remarkably informative presentation where you connected so many dots. And I would say it's particularly moving for me, somebody who grew up in New Mexico and went to school with a lot of Dene kids, and going home with them experienced how difficult transportation was. So just imagining what it was like to close access to border towns, which provided food and other goods at those times. So thank you so much. Mari Lopez is an organizer for National Nurses United, or NNU, and California Nurses Association, and the Medicare for All campaign. She works to promote racial equity in healthcare by focusing her organizing in communities of color and expanding Medicare for all language access. Welcome, Mari Lopez.
Excuse me. Thank you so much, Charles. I'm gonna go ahead and share my screen. I have a lot of slides here, folks, but I get through them fairly quickly and a lot of them are visual, so hopefully it'll be fun for you. All right, here we go. All right. Okay, so good evening to everyone. Again, I appreciate the opportunity to talk about the work of National Nurses United and the California Nurses Association and how nurses have addressed these issues. And I really appreciate all of you being here this evening as well. NNU was founded in 2009 at the inaugural conference, and it adopted as part of its platform, quote, win healthcare justice, accessible, quality healthcare for all as a human right. And our nurses have been firsthand witnesses to the substantial inequality in our healthcare system, so much so that they described it as a national assault by the healthcare industry. For them, the assault was so great that it was made a priority to be addressed and for a new standard to be created. And this is how the pursuit of Medicare for all was developed. And I believe COVID-19 shows exactly why we need a single payer system like Medicare for all, so that we may continue the chiseling away at the system's inequities. Data relevant to the people of color collected on the virus reveals that Black, Indigenous, Latinx, and Asians are disproportionately affected and die from COVID, something that we all know and that my colleagues have already shared. Black and Latinx Americans are 3 times more likely to become infected with COVID than white Americans. And the CDC estimates that between March and June 13th, COVID-19 related hospital admission rates were 4 times higher for Latinos than white people and 4.4 times higher for Black folks. Latinx represent 43% of all COVID deaths leading up to the age of 65. And the number of Asian Americans dying from COVID is also on the rise. For example, an article in the July publication of Health Affairs stated that in San Francisco alone, Asian Americans represented half the COVID deaths, even though they were only a third of the population. These numbers show the trait that the rate of infection of people of color is disproportionate to their overall populations. But what these statistics really reveal is cumulative barriers that have created health vulnerabilities for generations of communities of color that make us more susceptible to COVID-19. So though the disease does not discriminate, our healthcare system has set up people of color to be more vulnerable in the case of a pandemic. People of color are less likely to have a job that provides health insurance and are less likely to be able to purchase it on their own. Those who do have insurance are more likely to be underinsured as well, having some form of insurance but unable to afford the additional costs of using it, like copays and deductibles. These hurdles have conditioned us to believe that healthcare is a privilege and not a right, which serves as a means to maintain those barriers that keep us from getting the medical care. And when we do so, it is only when an illness becomes unmanageable or a pain too great. Consider that for most people of color, this establishes a really low bar of a standard of care. It fails to instill a practice of preventative care, nor strives to transfer an adequate level of health literacy. And while the pandemic has further unveiled the levels of discrimination within the healthcare system, it is the other aspects of racism in our society that has where COVID has disproportionately impacting people of color. In her book, So You Want to Talk About Race, Ijeoma Olua, describes racism as, quote, a broad and cumulative force. It is not a system that puts its eggs all in one basket. And racial oppression will interact with many privileges and disadvantages to produce a myriad of effects, end quote. In this virtual room, I don't think anyone here is surprised by the disproportionate numbers of infection and death rates among people of color from COVID. Outside the space and our communities, however, there's an increasing recognition and acceptance of the existence of inequality as contributing factors to these rates. For example, as recently as June, Dr. Anthony Fauci, director of the National Health Institute, admitted to the severity of the discrimination that exists, not just in our health system, but in our society, and that it contributes significantly to these poor health outcomes for Black and Brown people. I really want to show you, I'm going to show you a quick clip of this.
All right, we're not hearing the audio.
Oops. I'm sorry, folks, you're not hearing the audio? Oh, I apologize. I didn't have it set up correctly. I'm so sorry. We're going to go ahead and skip this because I think it'll be too hard to take too much time to try to fix her. So sorry. I was really looking forward to sharing that clip with you. But in it, what Anthony Fauci does is he comes on CNBC News and says, to the public and on live television, the system is flawed. It's filled with racism, and not only in our healthcare system, but within society itself. That basically sets up people of color to fail with regard to their health. So I thought that was really significant, and it kind of I think, again, just puts to rest any doubt about what we all know and believe about the racism in our healthcare system. And so the discrimination for hundreds of years now that has moved stealthily through our healthcare system and various other institutions, all the while claims of these cases have been and are commonly dismissed as being isolated incidences, are now supported by a steady supply of facts and overwhelming evidence that can no longer be disputed. What's also different today is an array of actions and activities taking place from the requirement of data collection on healthcare delivery, housing, employment, and food scarcity and insecurity, to spaces that are being created for discussing racism like the one we have today. And perhaps most important is the footage of police violence captured on camera phones. Video evidence that was also key during the civil rights movement in the 60s, in that it showed the American public's racism's violent tentacles. This evidence continues to quilt history with the present that lays out the cumulative and connective experiences of people of color and paints the reality of what has and continues to happen. So I mentioned in the beginning that NNU made a commitment to push against the healthcare industry, but nurses also are aware that illness and disease start prior to someone arriving to a hospital. And because nurses care about people, not just as patients, they've used their platform to call attention to and for an end to immigrant detentions and child separation, to urge police reform and to cease the shooting of unarmed people, and to fight to change our healthcare system, system like Medicare for all and guaranteed healthcare for everyone. NNU, the California Nurses Association, has participated, supported, and built movements to address these issues and to act against policies and practices that perpetuate discrimination and to address implicit biases and to stand as witnesses to this treatment of people of color, not just in healthcare, but in all aspects of society. RN sat with the Occupy movement. We joined protesting the immigration detention centers, even communicating directly with ICE to be allowed to treat those to provide treatment to those locked away and to make sure that the children were safe and healthy. RNs go to the aftermath of hurricanes and fires to provide first aid, all the while leading the march for Medicare for all. Nurses believe these actions are necessary to raise public awareness, but also deeply understand that it is policy that creates lasting change. Under COVID, nurses had to fight for their own survival when some in the healthcare industry took minimal to no measures to provide them with the personal protective equipment they needed. Not only as safety measures for themselves, but PPE also prevents the contamination of non-COVID patients. To date, 230 nurses have lost their lives to COVID. And taking matters into their own hands, NNU delivered to Congress a petition with more than 500,000 signatures to demand OSHA standards with guaranteed protections for nurses and all healthcare workers. NNU also sought a federal court injunction to order healthcare giant HCA, who failed to notify workers when they had been exposed to COVID-19, as well as pushing those who may have been COVID positive but not showing any symptoms to continue working. Recognizing that we needed public support, we mobilized people who supported the nurses by signing on to that petition and to call on their members of Congress. The activism of nurses and so many others demonstrate that when we fight back, we win. And today, nurses are driving the Medicare for All movement as a means of addressing and as a step in the process of dismantling racism in healthcare, and as a continuation of the legacy of the civil rights movement of the 60s. Many may not be aware that Medicare was instrumental in desegregating the hospitals in 1964 when the Civil Rights Act was signed into law. Title 6 of this act said, "No person in the United States shall, on the ground of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. Hospitals had to desegregate or run the risk of losing millions in federal dollars as a result.
Mari, sorry to interrupt. Did you mean to be showing other slides now? Someone is pointing out that we're still on the, or are we done with the slides?
No, it's actually, I've been moving them. Are they not moving?
They're not moving. Yeah.
Oh, I'm so sorry. Yeah, okay. Sorry. Let me see, it's saying that my screen sharing is paused. 1 second, I apologize.
You might need to get out of screen sharing and get back into it again.
Yeah, let's go this way. Let's try this one.
Welcome to the world of Zoom.
All right. How are we there? Are we on this? Are you all seeing the Title VI?
We've still got
No.
Fauci in front of us.
Okay, you still have Fauci. Okay.
But
How are we there?
there we
Title
go.
VI?
Yes.
Fantastic. Sorry about that, guys. Tech is, I'm not of the tech generation, as you might have all guessed. But we soon will all have to be. All righty. So let's actually move on to the next one. So while things look and feel really challenging with the global pandemic, climate change, police brutality, and inexperienced administration that seems to prioritize self-interest over the nation, all is not lost. In Nancy McLean's book, Democracy in Chains, about the neoconservative plan, which is about a neoconservative stealth plan to change the rules of our democracy to benefit the wealthy and mainly white elite, she also writes that the radical right believed that their plan had to be stealth because the majority of the population would not support it. And she's right. So in March, the Center for Strategic and International Studies reported, quote, "We are living in an age of global mass protests that are historically unprecedented in frequency, in scope, and size. The public's attention has been seized, and they are joining ranks like the Women's March, the Movement for Black Lives, and resistance to the immigrant detention centers, as well as a growing call for Medicare for all. And this is the latter that I want to wind down with. If we are to address systemic racism in healthcare, it must be done through wholesale transformation. This can be achieved through Medicare for all and guaranteeing comprehensive medical care to everyone in the country. As more and more people are unable to get the care that they need, even when they have insurance, it is becoming clear to them that the healthcare industry prioritizes taking their money while denying or overcharging for their medical needs. Today, more than 70% of the population supports Medicare for all, and that support continues to grow. And that's because MFA would provide comprehensive healthcare services, including preventative care, surgery, and hospital stays, prescription drugs, even dental and vision services, and much more. And MFA would eliminate monthly premiums, copays, and deductibles, so there would be no payment required for each doctor visit or procedure. We've been able to grow support for Medicare for all by organizing and utilizing simple steps that start with communicating our mission. Education is a big part of our movement building, as a large segment of the population have never heard of Medicare for all. While as a researching support among the public, it's really interesting to learn that the Spanish media rarely covers MFA if ever. And this was troubling to know that guaranteed healthcare would particularly benefit the Latinx community and population. So hopefully the information I've shared with you has inspired some of you, because if you haven't noticed yet, I'm an organizer, and so I'm trying to organize all of you to support Medicare for all. And so hopefully I've inspired you all to do so. If you're interested in joining us, there's a number of ways that you can participate. You can email us at Medicare for all if you'd like more information on how Medicare for all addresses systemic racism in our healthcare system. We'd love to share that with you. And just wanted to end that for the Medicare for all is not something it's not a matter of if, folks, it's a matter of when. This is going to happen. The community and population has been suffering so much under the system. And I think, again, COVID has really revealed much about not only about how racist our system is, but also how it leaves so many people behind. And more of us it's happening to more and more people. So as I begin to say, it's not a matter of if, it's now a matter of when. Thank you so very much.
Thank you very much, Marty, for your inspiring presentation. I feel honored to have my minor role here as a moderator to be able to participate with the three of you panelists. This was just remarkable. I would like to remind our other participants that you can use the question and answer feature to be able to pose questions, and we'll try to get to them as many as possible. Heidi and I are great ping pong players, so we're going to ping pong back and forth in asking the questions of the participants. So, and I'll start off. So one question would be, so how does the COVID-19 pandemic help us to better understand how racism is a social determinant of health, or as we tend to say in Latin American social medicine, the part of the social determination of health? And maybe if, Jamila, if you could start off with that question, please.
Sure. Well, I will say that in my opinion, I don't think racism is a social determinant of health. I think that social determinants of health are the result of racism towards people of color. And that can be debated. I've heard it be referred to a social determinant of health in other spaces. So I think that racism leads to those societal conditions that impact the health and well-being of people of color. And in terms of COVID-19, I mean, folks have said it, throughout this conversation today that COVID-19 has shed a spotlight on the inequities that we see in this country when it comes to healthcare access, as well as health disparities. And so everything from, the fact that we're seeing low-income people and people of color be disproportionately impacted, by job losses from the pandemic recession. These are also the same people that have lost their employer-sponsored health insurance. And on top of that, they are more likely to work in jobs that do not provide them with PPE and protective equipment. These jobs don't provide them with the paid leave that they deserve in case they do get sick or they do have to care for family members that are sick. And we're also seeing them disproportionately impacted by the health impacts. So it's really, on multiple levels, we're really, looking straight in the face of structural inequality in a number of areas when it comes to the COVID-19 pandemic.
Thank you so much for that answer. By the way, I really like your pushback against the question. I don't myself like the term social determinants because it kind of isolates particular things, and you can do a checklist as opposed to, again, this process of the social determination of health and disease seems to really get us onto a process level and not sort of isolating little things that you can count and put into categories. So thank you so much for that. I mean, one thing that's amazing about something like COVID is medical historians and anthropologists have argued for years that epidemics X-ray societies, revealing the structural pathologies that contradict the established truths that are so often used to cover them over, such as the idea that the US has the greatest healthcare system in the world, which of course, when so many people may not exactly experience it that way. Would either of our other panelists like to jump in on that question? If not, we've got lots and we can move on.
Yeah, no, I think Dr. Taylor hit it right on the head, and I absolutely agree with the pushback as well. I think it's very important to be careful with how we use these terms and the framing that we use, because it can completely eliminate the root causes of what we're actually needing to address when we're building responses, not only to this pandemic, but to all of the inequalities when it comes to achieving a certain quality of life and well-being, both at the individual level, but also at the communal level.
Thank you so much. So maybe Heidi, if you would like to move on to the next question.
Wonderful. Thank you all so much for those really extensive and deep kind of understandings of the structural conditions that have created the multiple challenges we face, especially that have been accelerated and amplified around inequities that have been exposed by COVID-19. Many of our participants in this webinar are really eager for us to be thinking proactively forward as you all come out of movement spaces for fighting for social justice and racial justice. really wanting us to think very deeply what we can do on a policy level to advance some of these movements for social justice that you've begun to map out in your presentations. And so to that effect, I'd like to narrow in on the racial trauma that was kind of central to part of your talk, Janene, and the historical trauma from pandemics, the accumulated traumas caused by displacement and disruption, and what on a policy level would a culturally appropriate mental health look like? And so, Jamila, you've also talked about the cumulative effects of racism as causing mental health issues in African American communities recently, and Mari, it came up in one of your slides. So, what are your kind of visions or some of the policies that you talked about? How will they address these kind of deeply entrenched issues that are related to mental health, not just physical health? Janene, would you like to start?
Sure. It's a very important question that we've been grappling with through the different phases of this pandemic and the impacts that it's had on our communities, both in exacerbating the poverty that we see through job loss, through the increased violence in the home that we're seeing from people being isolated with their abusers, to the sense of hopelessness that everyone from youth to those in their 30s and 40s were starting to feel, especially in our communities, being in the midst of this communal spread and having so many intrinsic relationships across our communities. So the loss that we're experiencing, we haven't even had time to really process everyone that has been and everything that has been lost from this pandemic. And so we've been very wary and thinking about all of these issues. And I think from a policy perspective, I love policy. It's one of my passions, along with community organizing. But a lot of my elders and the Indigenous experts that I work with bring this beautiful lens in weaving our cultural knowledge systems and lifeways into these critical analyses of these tools that we've been taught to use in order to push for progress and push for equality and deeply inequality and unequal systems that manufactured those inequalities. And from those conversations, one of the things that really resonates for me from their work is, particularly for our people, is place-based, culturally appropriate responses, language, frameworks, methodologies to inform what does a holistic policy look like to address these issues. And so it's from that manner of thinking, that systems-based approach, which I know has been like a catchphrase term now that people are using to try to deal and address all of the disparities that we're dealing with, including the impacts of climate change and the responses that are needed to transform our communities and our society and our economies. But for our peoples, that systems-based thinking has always been a part of our ways of knowing and our ways of living. And so to hold this and to respond to the issues that have been created by COVID, we have to center not only the mental health, but the spiritual health as equally valuable and important as the physical health of all of our peoples. And understanding that in that response, and this is where I also have issues with the way social determinants of health have been used as metrics. In that response, understanding that all these things are interconnected, that the health of the environment, the access to clean drinking water, the health of the land and the air, the ability of people to provide for themselves, the social cohesion of the community are all interconnected into informing and providing a quality of life and a sense of well-being that is paramount and is really, at the end of the day, one of the things that unites us all as humans. I know I was talking a lot about white supremacy and like the root causes of this, because that needs to be named, it needs to be addressed, but it also needs to be address that white supremacy also shows up in people of color and women of color. And we all have been conditioned under these systems to perpetuate and to carry out these characteristics. So we all have work to do. And that it's about aligning ourselves across our different, differences and operating from a place of intersectionality that holds both the racism and racial realities that of our lived experiences, but also our class based realities, and centers those connections that we have, as wanting, and the vision that we have, I think that we all have, that we want our people, our families, our loved ones, our friends, our communities to be safe, to be healthy, to have the quality of life that ensures that people can live up and manifest their gifts. And I think that, until our health policies can reflect that and hold that whole, we're always going to have this imbalance between addressing the physical health disparities, the very real physical health disparities, and the mental health disparities, and the spiritual disparities that are all important.
Thank you so much for that. I mean, that makes me think a little bit of your presentation, Mari, where you were really thinking about the way that the nurses take on this kind of very system level kind of need for transformation to rebuild a healthy society in many different ways. So Medicare for All is one of the ways that we address these health disparities, but also you talked about RNRN and our kind of work on racial justice and kind of defunding and redistributing police resources, et cetera. But I wonder if you would like to maybe take on this question a little bit, Mari, also to talk about how Medicare for All actually helps to uphold these other aspects of our work and move us toward that system level transformation that Janene is pointing out.
Yeah, of course. Thank you so much, and thanks for the question. I think this is really important. One of the things that I kind of cut out from my points and from the ideas that I shared was the idea that our society basically begins to evolve around ideas and begins to accept them. And so in order for us to really start getting to the root of racism and the systemic racism, not just in our healthcare system, but throughout the society, is to really to get folks used to the idea and normalize things within those aspects and components around that surround us in our environment. For example, one of the examples that I cut out was, gay rights and gay marriage, interracial relationships. Those are things that were rejected, 20 years ago, but now that they've become normalized. And I think in order for us to really start addressing some of these issues, to really start and just really getting down to the root of the problem, is to normalize access to healthcare and making and enabling it, putting folks on a path where they're really considering or understanding that healthcare is something available to them anytime when they need it, when they get sick, as a preventative measure as well. But because of the mindset that we are all in as communities of color, that we are conditioned to believe that no, if you don't have a job that doesn't have health insurance, then you are going to basically be on your own. I've worked over 20 years community organizing, and Janene, like you, I love policy and I love organizing, and I loved the roles that I played in the past of weaving the two together, teaching folks that policy is actually the people, and people are the policy, and that they have a responsibility in really shaping policy and becoming involved in the decisions that our leaders make. And so, but what I learned through that experience is the conditioning. Because I worked a lot with Latinx communities, and a lot of these folks were immigrants who came from countries where they were disappeared, or they experienced violence if they got involved against the government in protests, activism, what have you. And so coming here, their activism basically shrank, and they wanted to just kind of live under the radar. But working with them and showing them that that you actually have a voice here, and your rights are protected, really just was a shift in frame of mind, that now they had a responsibility. And I think, again, this is some of the measures that we need to change in our society. And I think Medicare for All is a means of doing that, by, again, really opening up the system for everyone to get to have access to it, to get guaranteed health care, and create it to be the norm for the country, like it is in every other country. No one ever thinks about it, like in the UK and France and Spain. They don't think twice about going to a doctor. Here we have to, people count pennies. They consider whether they can take off work or lose hours, and how much they have to pay, how much money they have for co-pays. And you know, and it's a system that again is antiquated, and we really need to change it, obviously. But I think once we do so and begin that reconditioning and of people and the belief that that they are entitled to get help is when we start that process.
Thanks so much for that, Mari. And really thinking about Medicare for All, one of the things that it reconditions around this question of mental health is normalizes that mental health itself would be a standard right of all people in this country, right? As including it is not something that's an exception to the package, but is integral to our overall health and well-being. So I wonder if, Jamila, you'd like to kind of pick up on this question of how policy can intervene in providing mental health resources.
Yeah, absolutely. I love that this conversation has also, turned into, how we can address not just the mental health piece, but I think healthcare broadly in an intersectional way from a policy perspective. I will say that, we need more than insurance coverage to address racism in the healthcare system. Medicare for All is a great model. And the ACA was a great model, and we need to move beyond the ACA now and expand coverage even more for people. But coverage alone is not going to solve the challenges that we see when it comes to racism in the healthcare system. Even for, speaking as an African-American woman and from the perspective of my community, even when we have health insurance, we still have experienced racism through our providers. We're not listened to through the healthcare system. It doesn't matter what our education level is, how much money we have in our pocket, whether we have Medicaid or, Blue Cross Blue Shield. That's just the reality. And so I think when we talk about coverage and having a universal healthcare system, that also needs to include how we address the bias and racism from healthcare providers. And so, one of the things that we're advocating for at TCF is not only to, get us to a universal healthcare system with coverage as well as access to care, but also what can policymakers be doing to address the issue around racism? Should we have some sort of national task force that sits within a friendly White House that can look at the issues around healthcare access and racism and healthcare coverage in a comprehensive way that really looks at some of the systemic issues, thinking about how can we link our policies related to climate, related to housing, education, economic justice, in ways that they do connect to healthcare, because all of these things are connected to healthcare. And I fully agree that mental health care should be a part of that conversations. I think one of the challenges that we've had in terms of access to mental health care is that coverage is a little bit better. It's not great. We still have a ways to go, but there have been laws that have addressed the parity issues around mental health, treating it like physical health. But we still lack access to mental health providers in, communities of color, in neighborhoods that are predominantly, inhabited by folks that look like me. And so it's not just about the coverage, it's also, finding those providers. Even for someone like myself, I have experienced challenges in trying to find a mental health provider that covered my insurance, that was close by. And so, we also have to get at some of those other challenges. And, I know we love to talk about coverage and universal healthcare, Medicare for All, and these other models, but we cannot talk about that in absence of addressing the racism that comes from within the system, that is entrenched within the system, and coverage alone is not going to deal with that.
So those are wonderful points. I'd like to draw together a very surprising thread that I see in all of your comments, which is to highlight issues of language and communication. It's fascinating that structural racism mutes the voices of racialized people in clinical settings, in epidemiological research, in the stereotyping that goes on in both health communication and also the news coverage of health that appears in mainstream news. I've referred to this fatal matrix as cumulative health inequities. And we think about the Institute of Medicine report on equal treatment. And one of the factors they identified in the way in which African-American Latinx patients get systematically worse treatment, right, than other populations, simply on the basis of race. And after compensating, after really eliminating the factors of socioeconomic status and type of health insurance, was the stereotypes that practitioners make about the communicative abilities of their own patients. She's not going to understand me. She's not going to take what I'm saying into account, therefore worse treatment. So this is a really important theme. My sense is if there's no communicative justice in health, there's no health justice either. So let me move on to the next question posed by the audience. What are your recommendations for where to start advocating for a more equitable, just government response to COVID-19? Specifically, the CARES Act, which doles out aid to hospitals proportional to their profits. Other areas that you feel citizens can significantly make an impact. I think you've all touched that issue, but any of you who might like to jump in there, we'll move along fairly quickly so we can get in as many of these wonderful questions that the participants are giving us as possible.
I have a brief answer to that. I say that, get out there and vote. We're in the election of one of the most important elections of our lifetime. We have seen that the response to COVID-19 to date has been inadequate. And that's not only coming from the White House, but I think also even members of Congress. Right now, they are focused on pushing forth a Supreme Court nomination when we are lacking a phase 4 bill that needs to respond to COVID-19. Millions of Americans continue to fall ill to COVID-19, continue to lose their jobs, continue to grapple with, online learning for their kids, lack of childcare, a whole host of issues. And I will simply say that, get out there and vote like your lives depend on it, because it does.
I would add to that, that folks, this is a really great time to be more in communication with our elected officials. It is really easy to shoot off an email, based on, on your interests, whether it be the HEROES Act, or just to let your congressional members, even your state representatives, to know the struggles or the things that you'd like to see during these challenging times. They measure the decisions they make based on the majority of their constituents, and so the squeaky wheel always gets the grease, right? And so when communities of color, because we don't speak out as much, we usually get the crumbs in the end as well. But I think even more so, our elected leaders know that we're paying attention. We're being surrounded and bombarded by news and changes of what's happening and progress. So I think that it's really imperative that people reach out to their elected officials, make a phone call, email, and just let them know what you'd like to see. And even, paying more attention also to, just not just to the new CNNs, but there's so much information available on through the internet, through social media, that folks could really weigh in on the relevance of decisions that are being made that have an impact on their lives. I think the fact that that Congress was grappling with whether to give people additional financial assistance was ridiculous. We know that people are hurting. People have lost their jobs, as Jamila have pointed out. People have lost their coverage. People are going hungry right now. There have been, the term is escaping, mutual aid spots that have been set up throughout communities to help folks who are struggling, because we know that there are people out there who are on the brink of losing their homes, that they're, again, food insecure, that people are going without their medicines because they can no longer afford them. So we need to really, to express the challenges that are happening on the ground, so that these these leaders will make sound decisions and vote for the interests of the public, and not, and again, push back against those decisions that Jamila again was pointing out, the fact that these corporations are getting tax breaks. It's just, it's ludicrous when there are folks, again, who are literally losing their homes. So, Mr. Congressional member is going to maybe lose his summer house. I don't give a crap. People are on the streets and, and losing their homes, and that's what they need to hear. And yeah, we really need to be pushing hard against the decisions that this administration and this Congress is making.
Janene, did you want to jump in there?
Yeah, so much. My answer is less simple, but I think first and foremost, I would strongly encourage anyone and everyone who cares about this issue and about these disparities and wants to ensure equality in COVID responses to push your elected representatives, no matter who they are, to uphold the rights of Indigenous peoples. And to be informed about those rights. You yourself as citizens, as well as our government officials, Indigenous peoples aren't just relegated to reservations. Over half of our populations live in urban settings, in urban areas. We all lack access to healthcare, despite the stereotypes that Indigenous peoples get free healthcare from treaty rights. Those treaty rights have been violated. Those obligations have not been met. And we continue to operate in a place of scarcity when it comes to any of the resources that are given to our healthcare facilities. And I think that I really want to point out that we've been dealing with these vulnerabilities and with these inequalities no matter who has been in office, no matter what party has had power. And so in this moment, I understand the urgency to vote. God, I'm voting too. I'm right there with you. But that is not where our power building begins and ends. We have to continue to build place-based responses and get to know the politics around your healthcare systems. Map out the service areas. Look at the neighborhoods that are being impacted by a certain service unit. Learn about the leadership in our healthcare facilities. They're not elected, but they are accessible. Start to break down those policies. Get to know your communities, your neighbors, and care about the issues and the barriers that they face. Because it doesn't matter if everyone gets health insurance if we don't have access to place-based care, to care that is culturally appropriate and that is appropriate to the context in which we're living in. And an example of that is that the hospitals that we have here, like I'm lucky to be living in one of the more developed areas, but the hospitals that we have here aren't outfitted to deal with the cancers that are resulting from generations of environmental violence and contamination that is impacting our public health. Our hospitals here aren't equipped to deal with the epidemic of missing and murdered and trafficked Indigenous peoples. They're not equipped to deal with the impacts to our children from living in the proximity of fracking wells and natural gas development and coal mines and coal processing centers. Like, we have to have the healthcare that match the needs of our communities, the healthcare systems that match the need of our communities, and that requires every citizen to organize, to become aware, to become informed, because an informed citizen is a powerful citizen and is a powerful and necessary ally to the people who don't have the voice or the resources to advocate for themselves. And all of this requires us to be diligent about dismantling white supremacy in the way that that shows up in all of our policies and all of the institutions of power that have a responsibility to represent and to protect all peoples within their area.
A wonderful answer. Thank you so much. I'm going to turn it back over to Heidi.
Beautiful. Thank you, Charles. We have a short amount of time left and handfuls of questions that folks want to get answers to. So hopefully we can get through at least a couple more in the 10 minutes that we have left today. One of the questions that came up builds on an issue that you brought up in your presentation, Janene, around really being thoughtful about how our responses to our immediate needs and our solutions can further exacerbate inequalities. And the question that arose was, this rush to get the vaccine, what's falling through the cracks and what are we missing? And I wanted to bring up that nurses also have a parallel concern that there's been a kind of push within the industry to use nurses as guinea pigs by requiring them to take these vaccines to administer care. And so these have resonances, especially as we're seeing disproportionate amounts of nurses of color die from COVID-19 They're above only 25% of RNs, but they're above 55% of deaths from COVID-19. And so there are huge concerns about how we're kind of in this Tuskegee experiment on indigenous peoples kind of moment that's getting replayed here. So I'd like to switch the question a little bit to ask, what does vaccine justice look like in this moment for you all? Would anybody like to take up that question, or?
I'll go ahead and start. For me, it looks like doing everything we can to address all of the things that should have been addressed 10, 20 years ago. That is providing, properly resourcing all healthcare facilities, ensuring that everyone has access to the healthcare that they deserve. And the focus and the rush to get a vaccine is very much rooted in a desire to return back to normal. And I think we are living in a moment and in a time where we're given an extraordinary opportunity to sit and reflect in our social isolation, to recognize the signs of endemic and systemic inequality that's around us and that affects everyone in one way or another, either primarily or secondary through our relationships, and to take this moment to recognize what is worth saving, like what in our society is worth saving, and to pit all resources that are being made available through the CARES Act and through private philanthropy, because private philanthropy has been making phenomenal structural changes in the way that they've been redistributing resources to vulnerable communities. Changes that we were told would take 30 to 50 years to make have been made overnight to address this urgency that we share as a human community. And I think that in this moment, we have to maintain focus on addressing the root issues of what has led to so many disparities, and ensure that the people who have power are being held to have that, to uphold that responsibility to, and not focus on a quick fix, and ensure that we're not further investing in band-aids to an otherwise violent system. We deserve radical transformation, and this is our moment to fight for it.
Jamila, would you like to chime in on this question? Thank you so much, Janene.
Sure. One of the things that I think about in the conversation about this vaccine issue, in COVID-19 is the fact that there's new polling that is going to be released by the Kaiser Family Foundation that shows that most African Americans would not take the vaccine if it became available today, per se. And part of that is due to the distrust in the healthcare system and that we've experienced for generations. And then I think also just the lack of trust in an adequate response to COVID-19. And so I just say that to say that, even when the vaccine does become available, and many of us in the health policy space are advocating for equitable distribution of that vaccine, there's still going to be some challenges in terms of, I think, both educating communities of color and then also getting them to agree to take the vaccine. And quite frankly, why would we blame them? As we've sort of seen, the lack of response to COVID-19. So just wanted to put that out there as something to keep in people's minds. I don't think the polling has been released publicly yet, but it will be in the next couple of days.
Great. Thank you so much, Jamila. And Mari, do you have a quick thought on this question?
Yeah, really quickly. So, as nurses, we're always fighting for access to quality and affordable care for everyone. And, one of the biggest fights that we're having right now as we're watching these in the pharmaceutical industry develop these vaccines is that they're getting ready to measure how much they can charge the general public. And as we know, it's going to disproportionately impact people of color. And like Jamila, I think it's going to take a lot of education, but, we're going to do everything that we can to make sure that it is available to everyone. And again, through policy changes, and Janene, I completely agree with what she said about the fact that we need wholesale transformation because of, and this is a great example of it, because of the fact that, again, when we have a system that's market-based, like a healthcare system that's market-based, then the only developments and only addressing of public health issues is going to be through profit. And so once we eliminate that, that sort of practice, then we're going to be able to really address equity in our system. So yeah, I think this is a really, really key importance, and it really reveals a lot about our healthcare system, the injustices. But again, through a program like Medicare for All, we can create a system where everyone has a vaccine, such as a time in the pandemic, without worrying about costs or availability.
Well, those were wonderful responses to an important question. I must say that no vaccine will cure the massive increases in social inequity and injustice that have emerged in the wake of COVID-19 and that are being turned into new structures of injustice in this country. We've talked about one simple thing you can do that might be able to help move some of these issues along. I'm so impressed with what you've said. I might suggest to our participants that they look in about, a couple of weeks at BCSM, that's the Berkeley Center for Social Medicine, Berkeley, berkeley.edu/events, to get this recording and share it with everybody you can find, because I think there's just so much. First of all, amazing information. As I said, the way in which you've taken things that usually get fragmented and put them together is remarkable, and it's been inspirational. So I cannot thank you enough. That is Janene Yazzie, Mari Lopez, and Jamila Taylor, and also our co-sponsor and good friends at National Nurses United. Thanks to Deborah Lustig for being able to help organize this. And thanks to all of you, the participants. Sorry we can't see you or hear your voices except through the Q&A. Sorry we couldn't get to as many of the questions as we might like. But for me, this has been a remarkable evening, and I thank you all so much.